All right. Jody, are you ready for me to take over here?
Absolutely. Thank you so much.
Okay, great. Well, it just gave me the warning this is being recorded, but we all understand that, and that is not a problem at all. So first of all, I just wanted to say thank you all for making some time for us. We are very excited about this program, and we're very excited about partnering with each of you at the local level to make sure that this program is successful for the kids that the children and families that we all serve. So we're going to do a brief overview of the Pathways to Success program, and then we've left, I hope, plenty of time for discussion. And it looks like we've got a smaller group, so I think that'll be good, so we can sort of address kind of individual questions as we're going along. Now, as Jody said, I'm Christine Herman. I'm the Bureau Chief of Behavioral Health for Healthcare and Family Services, and am the project program sponsor for Pathways to Success. So this falls under my purview to make sure that it rolls out in a successful manner. And I'm joined today with Kristen Kennedy. She also works at the Bureau of Behavioral Health. And she is our technical and programmatic guru. So if there are technical questions that people have, she'll be able to answer any of those. So just a couple of housekeeping items before we get into the presentation further. If everybody would keep themselves muted through the presentation, that just kind of helps to keep the background noise to a minimum. But if you have a question as we're going along, I think that Zoom has the chat function. Yes, I see it right there up at the top. So you can go ahead and send in any questions that you have at any point in time during the presentation. And then once we get done, we can go back and make sure that we address those questions. After we're done with the presentation, everybody can unmute themselves, and we can also have a discussion. Just wanted to make sure that you all have those different opportunities to ask questions. So as we've already said, we're going to provide a brief overview of the Pathways to Success program. But if you want more in-depth information and you haven't yet seen it, Healthcare and Family Services, we do have a dedicated web page for the Pathways to Success program, and it includes our slide decks and our recordings from a 3-part webinar series that we conducted this summer. And then there's a lot of other resources in there. There's some FAQ documents, our initial application that we submitted to CMS for the 1915I state plan amendment that gives us the federal authority to do this. And I think that Kristen can put that link in the chat while we're going along, just to make sure that you all have it in case you want to access any of those resources. So just again, if you haven't viewed those, I really do strongly recommend that you take some time to listen to them, because we're going to hit things at kind of a higher level today, but there's a lot more detailed information in the ones that we have posted. Okay, so I think that's all the housekeeping things that I have to say right now. So I'm going to attempt to advance my slide. Can somebody let me know if that advanced?
Yes, it did.
Good. Okay, Jody, great. Thank you so much. Okay, so we're going to start today by briefly setting some context for the current state of children's mental health services in Illinois, and I know that none of this will be a surprise to any of you. But really, to build an effective roadmap for improving the lives of children and families, we really do need to be able to meet the system where it's at today. And that includes understanding the scope of the challenges that we face. And you can see some of those listed here on this slide. So the children's mental health system that Illinois does have is primarily built upon the statewide crisis response infrastructure that's really most well known as the Screening, Assessment, and Support Services, or the SAS system. And as many of you know, the SAS system ensures that children experiencing a mental health crisis have immediate access to a mental health professional for crisis assessment and response, as well as access to short-term behavioral health services. Now, the difficulties in accessing providers of children's services, combined with the guaranteed access to services under the SAS system, has really led to an overutilization and an over-reliance on crisis services. So that's why you kind of see that first block there being crisis-oriented. Now, in addition, the system that we currently have is also largely built to serve adults. It tends to lack adequate access to community services and evidence-based practices. It tends to be compliance-focused rather than quality-focused. It has challenges with recruiting and retaining a workforce that's capable of meeting service demands. And that ultimately, all of these challenges really lead to current poor outcomes for many children and families. So the challenges that we just discussed, particularly the over-reliance on crisis services, are represented here in this utilization triangle. So the wideness of the triangle that you see at the top and as it tapers to the bottom, that wideness really represents the utilization of services in our current system. In a public health service model, the majority of individuals requiring mental health services should be served in the lower levels of care, such as the prevention through screening and primary care services, and then outpatient services that are provided at the community-based level. As the service intensity increases, the percentage of individuals requiring those services should actually decrease, which is consistent with illness prevalence rates. However, in Illinois, because the crisis system serves as the primary and most consistent entry point to services, we see an inverse effect. So our triangle is upside down. And you can see here in some of the stats that we have. Every year since its launch, the SAS crisis system has continued to grow. And annually, the CARES line, which acts as that centralized intake point for the crisis system, receives over 100,000 crisis calls, and community providers conduct between 35,000 and 40,000 crisis screens. Interestingly, recent trends have shown that the number of crisis screens has increased above 30,000 or so, but the actual number of hospitalizations has remained relatively steady. So this translates into an annual spending on psychiatric hospitalization of approximately $140 million and a hospitalization rate following screening of around 40 to 45%. And despite these significant numbers experienced in the crisis system, annually there's only approximately $90 million spent on children's community-based services. And that number has remained relatively flat for the past decade. So in order to right-size the system and flip our triangle, the right side the way it should be, we have to be able to shift our focus away from crisis and do a better job of supporting families that are seeking help. So the Pathways to Success program is really designed with these specific challenges of the Illinois system in mind. It's one component of Illinois' broader efforts to improve and enhance the behavioral health service system for children and also for adults. The Pathways operationalizes the children's mental health benefit of the state's 1915I Medicaid state plan amendment, and it provides access to new care coordination and home and community-based services to children with complex behavioral health needs. So this is for kids who are higher on the spectrum of needs for behavioral health services and who are also identified as NB class members. Now, it is built upon the values and principles of systems of care, establishing a service delivery model that is family-driven, youth-guided, community-based, trauma-informed, and data-driven. And the Pathways to Success program is targeted to launch on March 1st, 2022, and I'm happy to say that we are on target to hit that implementation date. So because we're utilizing system of care principles and building pathways to success to meet the individual needs of youth and families, while also enhancing the overall system, we are anticipating that these outcomes that you see here on the screen will be achieved. that we will be able to improve family functioning and reduce caregiver stress, that we will ensure more stable living situations for children and youth, including fewer out-of-home treatment episodes, that we'll be able to increase family and youth involvement in services, that we'll be able to increase the use of evidence-based practices with a particular emphasis on increasing access to mental health services and supports that are provided in the home and community-based setting. We're going to be able to improve school attendance and performance for children and youth, and we're going to be able to reduce contacts with law enforcement and child welfare that children currently experience. And in many ways, they experience this because we do not have access to all of those other services that we know that we need. So we have some lofty goals, but we are very committed to meeting these goals. And other data has shown that when you implement these types of system of care initiatives, these are the outcomes that you can expect. So we'll start quickly by talking about, well, which children are actually eligible for the Pathways to Success program. So in order for a child to be enrolled, they must meet all of the criteria that you see here on the screen. They have to be eligible for Medicaid. They have to be under the age of 21, have an SED or an SMI, so serious emotional disturbance or a serious mental illness, and then demonstrate a need for intensive services pursuant to the IMCAN's decision support criteria. So that is the Illinois Medicaid Comprehensive Assessment of Needs and Strengths decision support criteria. Now we're going to go into a little more detail about that so you kind of have an understanding of how that works and how we're identifying kids. So the Illinois Medicaid Comprehensive Assessment of Needs and Strengths, the IMCANS, serves as the standardized mental health assessment and treatment planning tool for community mental health in Illinois. And at the core of the IMCANS is the child and adolescent needs and strengths and the adult needs and strengths assessments. So those two components were put together to create the Illinois Medicaid Comprehensive Assessment of Needs and Strengths. So these community-metric tools contain a set of core and modular items that are rated using a 0 to 3 scale, and that 0 to 3 is based on the urgency for intervention related to the item being scored. The IMCAN's decision support criteria stratifies children into service tiers based on the combination and the complexity of the actionable needs that were identified in key CANS items from multiple domains. So this approach is really intended to help the state identify children who are in need of intensive home and community-based services using a standardized set of criteria that evaluates a child's individual assessed needs. So just to give you a little background, we are working with Dr. John Lyons, he's the creator of the CANS and the ANSA, to develop that decision support criteria model that is Illinois specific. They've done this in other states across the nation, but we want to make sure that what we're doing is Illinois specific. So in the Illinois model, children in Tier 1, which is known as high fidelity wraparound, and Tier 2, known as intensive care coordination, will be considered NB class members and then will be eligible for the Pathways program. So we also convened a work group of licensed clinicians from the Department of Human Services, from Child and Family Services, from our managed care plans, and then also from community providers to do a full review and then to provide feedback on that decision support criteria to ensure that it's clinically sound and that it makes sense in the field for people who are actually going to be utilizing the tool and then sending us that information. So let's talk a little bit about the eligibility determination process so that you all can kind of see how that flows. So it starts with a child who's receiving services from a community mental health center or behavioral health clinic. So the provider will complete an IMCANS and then upload that data into the HFS IMCANS provider portal. And they'll do that within 10 business days of completing the IMCANs. Then on a weekly basis, HFS will apply the eligibility criteria that we discussed earlier, including the decision support criteria, to all of the new IMCANs that have been entered into the provider portal to determine whether or not the child is eligible for pathways. Now, it's important to note that families are also going to have the ability to directly submit a request to HFS for an eligibility determination if they also send in a copy of the child's IMCANs. That'll be separate and apart from this automated process. So there's a manual way for them to request that an eligibility determination be made, as well as this happening on an automated fashion. So children who are stratified into Tier 1 or into Tier 2 and then meet all the other eligibility criteria will be determined to be NB class members and eligible for Pathways to Success. They'll be given 6 calendar months of eligibility in the program at that first eligibility determination. So once that child is determined eligible, we're going to auto-assign the child to a care coordination and support organization. I'll tell you a little bit more about those in just a moment. And that'll be based on where the child lives. So children who are not stratified into Tier 1 or Tier 2, while they will not be eligible for Pathways and they will not be considered NB class members, they're still going to have access to the full array of other Medicaid-covered behavioral health services. They would just not be eligible for the Pathways program. So following this eligibility determination and care coordination and support organization assignment process, HFS is going to issue a notice of eligibility that's going to come through the mail to the child and the family, along with separate notices that go to the care coordination and support organization and the child's managed care plan if they are enrolled in managed care. And finally, HFS is going to reassess a child's ongoing eligibility for Pathways using updated IMCANs information from the provider portal prior to the end of the child's 6-month eligibility period. So that's kind of how that whole process runs. So once they're determined eligible for the program, children are going to have access to these 7 new home and community-based services. And that includes care coordination and support, or CCS, family peer support, intensive home-based services, respite, therapeutic mentoring, therapeutic support services, and individual support services. We're going to go into a little bit more detail about these services today just to kind of give you an idea of how they work. But again, we did a webinar specifically on care coordination and support, and then a webinar specific on those other services. So if you want more detailed information about them, I just encourage you to check out those 2 webinars that are posted on our Pathways webpage. Okay, so first of all, let's talk a little bit about care coordination and support. This is an evidence-informed, structured approach to care coordination that's based upon the values, principles, and processes of wraparound. So we're talking about, high-fidelity wraparound, the evidence-informed model that we have. Care coordination and support includes a broad set of activities that are designed to assess, plan, and monitor the service needs of the child and the family. And those include what you see here on the screen. So engagement and outreach to children and families, including education on systems of care and wraparound. Organization and facilitation of a child and family treatment team, or a CFT, that meets on a regular basis. Reviewing and updating the child's IMCANs on a regular basis, which includes the identification of needs and strengths and the development of an individual plan of care or a service plan. Crisis assessment, safety and prevention planning, and response activities, which includes mobile crisis response responsibilities. We'll talk a little bit more about that. Coordination and consulting with providers and other formal and informal supports involved with the child's care. This includes working to help transition children from institutional settings to a community-based living arrangement. and then referring, linking, and following up with service providers and social service agencies that are offering the services recommended by the child and family team and then included on the service plan. So that's kind of our core service, the care coordination and support. So while each family can expect a core set of interventions and services that we just discussed, they're also going to be tailored to the unique needs of each family. So care coordination will be provided in one of two levels or tiers of intensity based on the family needs. So what you see here is the high fidelity wraparound. This is the highest level or tier of care coordination, and it's designed for youth with the most complex needs. So these youth typically experience crisis episodes, may be involved in other child systems like juvenile justice or special education, may have psychiatric hospitalizations, lots of mobile crisis response. So this is really those kids that have really intense, complex needs. It includes a 1 to 10 care coordinator to family ratio, a child and family team meeting every 30 days, the IMCANS and crisis prevention plan reviewed every 30 days, and then a minimum of weekly contact with each family. So we also have the intensive care coordination tier, and this is for youth with less complex needs, but who still need an enhanced level of care coordination to meet their goals. So this tier includes a 1 to 25 care coordinator to family ratio, child and family teams every 60 days, IMCANS and crisis prevention plan reviewed every 60 days, and then minimum contact with each family every week. So because these services are the foundation of the Pathways to Success program, HFS is establishing care coordination and support organizations, or CCSOs, that are specifically designed to provide the care coordination and support services that we just discussed. These care coordination and support organizations, or CCSOs, will be provider-based organizations that will serve as localized, accountable hubs with responsibilities for covering a specified designated service area, or DSA. CCSOs are expected to be ambassadors of the values, principles, and philosophies that underpin the Pathways program. CCSOs are responsible for coordinating care for children with significant behavioral health challenges and their families who are enrolled in Pathways. Also, families that are involved in the Family Support Program, Specialized Family Support Program, and our SAS program. These CCSOs will also serve as the designated mobile crisis response provider within their identified designated service area, and they will be required to respond to all crisis referrals from the CARES line on a no-decline basis. So we have a specific process that we are utilizing to select these care coordination and support organizations because the qualifications that they require are specialized, and we need to make sure that we have organizations that are prepared to complete the activities that we need them to do. So as you can see here on the screen, this is kind of the process that we have used. We released an RFQ, or a request for qualifications. We asked for responses by October 1st. I'm happy to say that we received good, robust responses to that. The applicants identified which of the DSAs they were interested in serving as part of that process. We are now moving into this third step, where we will have a team of 3 reviewers who are going to be assigned to review the applications for each DSA. We have a standardized scoring tool, and we have a mix of staff from various areas that are going to take a look at these applications to be sure that we are looking at this from multiple perspectives. We are anticipating that we're going to announce selected CCSOs around November 15th, and then they are going to start working with us, with the University of Illinois, and with our managed care partners to start preparing for implementation. We are also going to request that they pass a readiness review that is going to be conducted jointly between HFS, our managed care plans, and the University of Illinois. to show that they are ready to start providing these services before we start enrolling children. And then they're going to have a 30-day cure period in order to take care of any deficiencies that we find during that readiness review. So we're very serious about making sure that care coordination and support organizations are well supported and that they are ready to go before we start enrolling children. So here's a little bit more of that timeline for how this is going to roll out, just so that you can start to see how things are going to start moving. We are anticipating that mobile crisis response transition to any new providers that become care coordination and support organizations, but were not previously our designated mobile crisis response providers, will start in February. And then we're going to start more of a staged rollout, starting roughly in the southern part of the state with those care coordination and support organizations in March, moving then to North and Collier counties in April, and then finally moving into Cook County May 1st. Now, there may be some adjustments based on who is ready when. So it could be that not all of the southern CCSOs are starting services in March, but this is roughly the scale that we're going to try to stick to. So just a couple of more slides to give you a little more information about the other services that we discussed earlier, because there are a total of 7. We've spent a little bit more time talking about care coordination and support, so we'll briefly review these. The first is family peer support. So this is really geared towards the caregiver of the child, really want to enhance their capacity to help manage the child's behavioral health needs. And this will be delivered by staff who have lived experience and who've gone through a specific training relative to being a family peer support provider. We're also going to be offering respite, which we know is important. You know, sometimes families just need a break. They just need some time apart. So they can have up to 7 hours a day, 21 days a month, or 200 hours a year of this particular service. We're also working to bring on therapeutic mentoring so that we really have those individuals that can spend time with children in the community, teaching them new skills, practicing those skills, and helping the child to better understand pro-social behaviors and better integrate into the community. We're also going to have our intensive home-based services. So this is a team approach within the home, driven by a clinical plan provided by a clinician that targets the most problematic behaviors that the child is having in the home, and also offering an additional team member who is the support person that is doing a lot of the practicing with the family and the child to implement that clinical plan within the home setting. We're going to be specifically training practitioners on the use of PracticeWise, which pulls in lots of evidence-informed and evidence-based practices and offers suggestions and actual practice in how to bring those guidelines to the treatment of the family in the actual living situation. So this one is going to require some additional training for providers who want to offer this service. We also have therapeutic support services. These are things like art therapy, dance therapy, my personal favorite, equine therapy, and there's a $3,000 per state fiscal year for each youth. And then we have our individual support service.
I think we lost you, Christine.
Hi, this is Kristen. I think Christine got kicked out of the meeting entirely.
Oh, no. But was she going to try just to log back in?
Yes, I'm sending her a text now. Sorry about that. Hold on one second.
Thank you.
Christine is dialing back in now. It seems she got completely booted out of the Zoom for some reason, but she's joining back in.
Okay.
Sorry about that.
Hey, that's technology, right? Do you have, are there some slides? Do you have something that you could share, Kristen, or I could put up, or anything that would help her if she's just dialing in, or is she?
She is joining the Zoom again. I believe she's
Okay, I didn't know she
in
was calling.
and she's working on joining audio.
Okay, great, thank you.
Yeah, sorry.
Okay.
Okay, can you all hear me now?
Yes, we're good, thank you.
Well, as I said, it has been an interesting tech day, so apparently I got completely booted out. Or Jody was getting very bored with the presentation and decided to just end it.
Not at all.
Well, I think that the last thing you may have heard was talking about the therapeutic support services. Is that right?
Yes, I believe so.
Okay, so just very quickly then, the other piece that we have is the individual support services. These are things like summer camps, weighted blankets, just some of those softer supports that can really help kids. And there's a $1,500 state fiscal year limit on those. So one last slide, and then I will stop talking. We'll get this slide deck out to everybody, and these are just some of the other resources that we thought might be helpful for anybody that's interested in the program. So with that, I will put the email address up here. This email address is where questions are coming in, and we are doing our best to respond to each of those questions, and then also doing our best to update the Q&A documents that are on the website.
And we're not, yeah, I was gonna say, on the slide, we're not seeing the slide. Was that, do you have an email we could put in the chat room or something, or?
Hang on one second. I can
Great.
get that to share. How's that?
Yes, awesome.
All right, well, apologize for the complete technical meltdown, but I think that we do have some time now to take questions.
And we've got a couple in the chat box so far. The first one that I see here, what was the rationale for creating DSAs that did not align with the DMH regional boundaries?
So our designated service areas were based on the previous lands. I don't know if you all remember that term, that we then started calling designated service areas for SAS and mobile crisis response. We had to redraw those areas so that care coordination and support organizations could have the volume of kids to be sustainable. And they did not necessarily align with the DMH regions. So that's something that we're discussing with DMH in collaboration to see if there's some ways that we can address that particular issue. But it was really about needing the volume of kids to make these viable organizations.
Okay. And then we also had a question regarding the fidelity standards and HFS plan to staff the program given the workforce shortages that we're seeing.
Workforce is a huge concern for all of us. And this has been raised quite a bit. So there's a couple of different things. We have applied for some ARPA funds, the American Rescue Plan. And part of those funds will be going to help support agencies in hiring staff and help to offset the costs associated with staff having to be trained before they can actually start seeing clients. And then we're going to work with each of the individual care coordination and support organizations that are selected to understand, where they're at in their staffing, how much capacity they can take on when, and just making sure that we're being very thoughtful about how we do that in terms of the enrollment of kids and supporting the care coordination and support organizations in getting their staffing up to where it needs to be.
Question. I reside in Champaign County and was a part of, we had a countywide system of care. And then there was also an implementation for statewide system of care for young people that were involved in DCFS. Is this different? And one of the things, and why I ask if it's different, is this funded for a certain amount of years? A lot of families were devastated after that funding left, and there was no sustainability.
Yeah, is that Chandra?
It's Chandra.
Yeah, and you were part of the Choices Project, right?
I worked with Choices, and then also in Champaign County, we had a system of care. Yes. Kristen, you went out. I couldn't hear you.
Are we muted?
I'm not sure.
I know, I'm looking to see. It doesn't look like Kristen's connected with the audio at this point.
Okay.
Christine, are you still on? Bear with us. They might be calling back in.
Okay.
Let me check and see. There's nothing in the chat box at this moment. Yeah, I think they're probably trying to call back in. Neither one of them are connected by audio at this point. Thanks everybody for your patience.
Well, Jody, if since it is being recorded, my other question, if they do come back, is why is the value of cultural and linguistic competence no longer a part of the system of care values? When like the primer, building a system of care primer talks about it being a part of best practices as well.
Okay. I've got that here. We can follow up if they're not able to get back on. I can follow up and get the answer to that for you, Chandra.
Thank you.
Absolutely. Yeah, I'm not seeing, it looks like Kristen's off both audio and video here. So let me send a message here and I'll see if they're just having complete issues. So hold on just a sec. Hi, Kristen, are you back on?
I am.
Okay,
I called in from my cell phone. I think the state just lost internet
Oh,
completely.
wow. Okay. Oh my goodness. Okay.
We're having a tough computer day today, apparently. So I'm sorry about that.
No problem. So, and let me see here. I think that was, and Chandra had a follow-up question as well, but I think we didn't hear your response to her original question.
Yes, I'm sorry. I lost audio when Chandra was asking her original question, I think about the choices pilot.
Yeah, so I was just asking when the system of care through HFS during that time ended, families were devastated because they no longer had that coordination. What is this going to be sustainable now because it's a part of Medicaid? Have you thought about re-engaging those families again? I'm adding more to that. And then my follow-up question was, since cultural and linguistic competence is a part of system of care values, why has that been erased from the values now?
Yeah,
So,
oh, Christine, are you back?
I'm so sorry. Can you all hear me? I literally went into a black hole somewhere.
Yes, we can hear you.
Oh my gosh. Okay. So, Kristen, you were going to start responding. Please go ahead. I don't want to interrupt.
Yes. So, Chandra, to answer your question, since these services are part of Medicaid and they are part of, or will be part of our state plan, we are anticipating these are going to be permanent services. So that drop in services that you guys experienced through the Choices Project should not happen again. And that's one of the reasons we've done that designation with the CCSOs, is to have a specific identified provider with accountability and requirements to continue doing services. The other part of that is the culturally and linguistic competence requirements that are part of systems of care are still part of pathways. We just chose to highlight a couple of them, but you'll see specifically in some of our overviews that we did that is still a huge component of the program, and something that is going to be a key core area for all of our providers.
Yeah, and Chandra, I apologize. We didn't cover all of the system of care principles. So it really wasn't an intentional leave out of that. We had just highlighted a few, but that is a key core component of everything moving forward. So probably should have highlighted that one.
Well, because
so
I'm looking at your website too, and it doesn't say it anywhere. It says culturally humble, which are two different things than culturally and linguistically competent. Cultural and linguistic competence is a different, like that's different than cultural humility and being culturally humble. And so I pulled out my primer because I've attended the primer twice with Sheila Pyrus, and just kind of I know that at one time you all were getting technical assistance from her. Are you still utilizing her information? And then I also understand if things have evolved, but just curious to know why it's shifting.
Yeah, that's a really interesting point. And we have gone back and forth between cultural and linguistic competence and cultural humility. Cultural humility, we chose to adapt that and put it on the website because that was a recommendation from our equity councils that we work with. We are still teaching to cultural and linguistic competence when we're doing our wraparound training. We are working very closely with Sheila and with John O'Brien and Diana Simons on that training. We've also added Shamika Williams from Oklahoma, who also works very closely with Sheila. So we're getting as much guidance in that area as we possibly can at this point. So I know there's been some debate about should you be, promoting cultural humility or linguistic competence, cultural and linguistic competence, and I guess the answer is we're doing both. But we took the recommendation of our equity councils on sort of highlighting the cultural humility aspect.
Okay. They are very two different things. I just want to make sure that as you are doing your planning, they're two different things, and they touch two different ways. And we can talk about this more offline, but I just wanted to just know that those are two different things. And when you are working with families, and cultural and linguistic competence is not a part of the planning process, there will be a lot of families that will not thrive.
It's a really super important point. We're also working with Regina Kreider from the Youth and Family Peer Support Alliance, who's making sure that we're staying on target with all of those things that you're talking about. So would certainly welcome a conversation with you and her, and just making sure that we've hit the right notes.
Okay, thank you.
Any other questions from folks today? Well, it looks like we don't have any further questions. maybe there'll be follow-up. If we do have some, we'll reach back out with you, Christine and Kristen. Appreciate your time speaking with us today. Again, this is recorded, so we will post this to our members, so that might solicit additional feedback and questions. Again, I'll follow up with you. And just thank you so much. Thank you for your time, and hopefully you get your technology straightened out today. I'm sure it's going to be a little frustrating.
Yeah, and I don't know if everyone heard me, but the other thing that I'm very interested in is understanding how best to connect with all of you as we are rolling out this new initiative. As care coordination and support organizations are coming up within your areas, how best can HFS and 708 boards collaborate and communicate to make sure that we are doing everything that we can to make this successful. That's really kind of some of the feedback that I'd like from this group.
Yeah. This is Ron Melka. I had a question as well. As you were talking, I thought of it. What's the connection between the juvenile courts and the Juvenile Department of Corrections? DCFS used to have the Unified Delinquency Intervention Services. That was kind of a wraparound plan with 5 different areas of a child's life. And I didn't know if those assigned to the juvenile court or a diversion program from the Department of Corrections would be part of this.
Yeah, Ron, really important point. And we anticipate that a lot of our kids enrolled in this program are also going to have contacts with the court. We're going to be looking at sort of the statewide approach to making sure we get information out, but then very much at the local level, we want to connect the CCSOs with the local courts and local juvenile justice so that everybody understands who's playing what role. And when we have a kid that is involved with JJ, that we're incorporating all of the components that they need within their broader plan of care to make sure that we are addressing those issues and that we've got any of their JJ contacts included in that team as much as possible. So we're really going to be looking to the local agencies for some guidance there and to get the relationships between the CCSOs and JJ and courts established.
Okay, yeah. Many years ago, UDIS had a UDIS coordinator to divert kids from the court, and it was part of the probation department, at least in Cook County, juvenile probation down at Hamilton Courthouse.
Gotcha.
And that might be a good way too to have a liaison with the probation departments that have most of the kids in DOC.
Excellent suggestion. And I'll follow up with you more on that.
Okay. Yeah, I used to be on the
great.
UDIS committee and the statewide UDIS task force.
Great.
And Christine, we also have another question from Deanna in DeKalb. She had to head out, but her question is, she'd like to learn more about how to connect without a CCSO in their county in order to avoid duplication and where they can be supportive.
Yeah, that would be great. I mean, I wonder if we could start, setting up kind of individual meetings with boards that are interested in meeting with us and doing a little bit more of that deep dive at the local level. Jody, is that something that you could start sort of or organizing for us, or could we use you as kind of that conduit to get those individual meetings with folks? Is that an appropriate ask?
Sure. I mean, yeah, I'll defer that to the executive committee, but I'm assuming so. I would be happy to help in any way.
That would be fantastic. We would love to get those meetings on the books, as soon as possible
Okay.
to start that process.
Okay, great. Any other items or questions?
Well, I am so sorry about all of the technical issues. I don't know what is happening today, but I appreciate your time and your interest in this topic. And I'm looking forward to a lot more collaboration.
Absolutely. Well, we thank you. Hope all gets straightened out, and
Gosh.
thanks for your time. Both you.
All right, Jody, thanks. Thanks,
Okay,
everyone.
we'll be in touch very soon. Thanks so much.
All right, great.